Hi guys, let's talk about blood transfusions. So a little bit of a quick review. Blood transfusions could be used for several things or several instances or scenarios on patients. For example, if a client experiences some anemia or suffers from iron deficiency anemia. Same as perhaps they have aplastic anemia where they are needing um, red blood cells, or perhaps the client suffer an injury where they're losing blood. Blood transfusions are also used. So that's just kind of like a quick review and overview of blood transfusions. Now, let's look at blood transfusions in the sense of what are they composed of? Well, they're composed of sometimes packed red blood cells or platelets, or sometimes it's plasma. But within the red blood cells, we do have these two, three, actually four types of blood. And they all have to be with the type of blood the individual is. And then also there are RH factor. So you could have, you could be, or a client could be A positive or AB negative. It could be A positive or A negative, B positive, B negative, and O positive and O negative. Um, Someone that is O negative is called the universal donor, and someone that is AB positive is said to be universal recipient, meaning they could receive blood from really anyone. With O negative, they could donate blood to really anyone. Based on that Rh factor and these antigens that we have, certain blood types can only receive from particular one. For example, A positive people can give blood to A positive and AB positive. However, they can receive from A positive, A negative, O positive, and O negative. So this is also something handy to kind of know in general. But in the overall spectrum, we kind of know that O negative is universal donors, and then OB positive, they're universal recipients. Now let's look about, the different types of blood products. So I kind of mentioned red blood cells, packed red blood cells, which are literally just red blood cells. We have platelets, and then we have plasma, and there's something called albumin as well. Let's look at them individually. So packed red blood cells are usually given for anemia or some sort of blood loss. Um, there is a large fluid overload risk. For the most part, it's said that if someone receives one bag of red blood cells, which normally has about 300 mLs, 250, 280, somewhere around there, they should increase in their hemoglobin 1 point. Platelets are more for when someone has low platelet count or something called thrombocytopenia, or perhaps they're bleeding because their coagulation, their platelets are low or inhibited. Um, so normally, you see an increase by 5,000 when you give one bag of platelets. Fresh frozen plasma, it's given when someone has a lack of coagulation factors. For example, someone that maybe is on an anticoagulant like warfarin, you might receive fresh frozen plasma if you're going to go into surgery. And albumin is usually given as a hyperosmolar solution. It sort of makes the vascular system kind of bulky and so maintains the blood pressure as well. So let me ask you, um, What do we really need um, between orders, like doctor orders, supplies, or things, or nursing consideration in order to give a blood transfusion? Well, I'm about to tell you. So, number one, and first and foremost, we do need a physician's order. So, a physician is going to write an order saying this client will need 1 unit or 2 units or however many units the client orders. They're also going to say that put an order for type and cross. They're going to type, meaning they're going to find out, they're going to draw blood on the client and find out what type of blood they can receive, and then cross match it to see if they have any Rh factors and any antigens and whatnot. So that way, when the order is sent to blood bank, they know what blood to send up to you. Then the second most important thing is that you got to get a consent from a client. And when we get consents from clients, we need to consider any restrictions like religious restrictions, cultural, and that they understand the risk that comes with blood transfusions. Although the risks are low, there's still some risk. So we want to educate them. We want to let them know everything that kind of goes with it. And then witness the consent. You have to have a large IV, 18 and 20 gauge size is the preferable size for blood transfusion. This allows for that cell, the red cells, to not get squeezed and sort of damaged. It is considered or to be given with a special tubing. We call it the white tubing, and it has a filter. And this little filter sort of filters if there's any quag, like a clot or anything in the bag. It just doesn't allow it to go in through the tubing and, of course, into the patient. It's always given with normal saline. And also, at least red blood cells are given in a pump most of the time, unless it's a mass transfusion, then they might hang it, fast. But um, most of them is on a pump. Now, uh, platelets or plasma and platelets can be given without, a pump. We send orders to the blood bank and we pick it up from the blood bank. Now, blood bank could be maybe in a different part of your hospital, and maybe the nurse has to walk up there and pick it up, or sometimes they send it through these tubing, um, like um, like an internal tube that kind of ships directly to your unit. Now, once you pick it up from blood bank or they send it up to you, you have a very small window to administer this blood, okay, or this blood product. It's 30 minutes. If you, for whatever reason, you lose the IV or something happens with the client that you cannot administer this in 30 minutes, you have to return it back to blood bank. You cannot like refrigerate it in the unit or leave it out. You have to send it back. Another window that you have to consider is that once you start the blood, you have 4 hours to administer the blood completely. And this is due to the risk of, getting bacteria to grow in there and for the actual blood to go bad. You have to do your 2 identifiers with another RN to verify this information. So there's like a dual sign off for nurses. We verify that you have the right patient with the right date of birth, that their correct blood is it's on hand from the type and cross, that you receive the correct unit. Every unit is labeled with specific numbers, and I'll be able to show you that in a picture shortly. And then you start the blood. You take vital signs before so you can get a baseline of what the client looks. And then you monitor the client for 15 minutes. You do not leave their side, do not leave their literally their room or their side for the first 15 minutes, and you're constantly taking bottles, maybe every 5 minutes or every 10 minutes. And then after that, every 30 minutes to an hour. Once the blood is finished, you take vital signs again. So the vital signs are very frequent, but they're going to come very crucial at the beginning during those first 15 minutes, then every 30 minutes to an hour, and at the end of the conclusion of the blood transfusion. Something to also keep in mind is maybe potential complications from the blood transfusion. For example, maybe they develop an allergic reaction, or maybe they have a severe anaphylactic reaction, or they develop something called fluid overload. Because we're giving them so much fluid with the blood, you have to consider how fast this blood is being administered then. So a couple of things to keep in mind when you are administering blood for the first time. You want to start slow. Two reasons for this. Well, first, to not overload them. And then number two, because if a reaction were to happen, it's less blood amount in their body than if you would have started at a very fast rate. So for the most part, we do start a blood transfusion between 75 mLs and 100. That has been my experience. And then after the 15 minutes, then we can bump it up a little bit. If you started at 75, then you bump it to 100, or if you had it at 100, maybe you bump it to 150 perhaps. If a reaction ever happens, like a severe reaction, then you do want to stop the blood immediately. And we'll talk about what to do on these steps here shortly. Here's the tubing. As you can see, it has two spikes, one for saline, one for the blood bag, two rolling clamps, then your chamber with your filter, and then another clamp towards the patient side where you can control stopping both saline and blood. Here's your sort of your identifiers, or how your bag label looks like. You're going to have like collection day, unit number, when it expires, when blood bank dispense the blood, what type of blood is, the RH factor, if it's positive or negative, and any kind of um, specialty that the bag might have. For example, sometimes a client might need eradicated white blood cells from because their immune system is responsive. So those are special cases. Another thing that I'll show you is that both fresh frozen plasma and platelets are yellow. And the way to identify them is that frozen plasma is light yellow. And then platelets are sort of like opaque. It has a more dark color to them because of the opaque. It's not really transparent or translucent or light. So that's a good way to identify it. Let's talk about the different, more in depth of the complications that could happen or adverse reactions. So the lowest one would be sort of febrile non-hemolytic reaction. This is kind of common. It just means that there's some antibodies that literally are kind of reacting from your own immune system against this donor blood, and then leukocytes, white blood cells, and then they elevate your temperature. It's kind of common. Possibly the client will experience like an increased temperature of just 1 degree or more. Or the client might have some headaches or redness of the skin, body aches, or maybe a little chills from just a little fever or the elevated temperature. On here, what we do is that we stop the infusion and then we give Benadryl, an antihistamine, and we might give Tylenol for the pain or the temperature. So this is kind of like the lowest reaction or adverse reaction. Then from there, you jumped on to allergic reactions. Um, m- Common, it's common in people with normal allergies or that they might have allergies of something. They could be more reactive if they get a blood transfusions. And basically what it means is just that the individual is sensitive to that donor plasma protein. And so then the immune system reacts again, and then they'll experience redness, itching, or even hives at times. And it can get as bad as an anaphylactic reaction. For this instance, then we for sure stop the reaction, the transfusion, excuse me. Um, Give an antihistamine like Benadryl. We can give a steroid like corticosteroid. And then worst case scenario, if they go into anaphylactic reaction, then epinephrine. Now, the most serious of these complications is the I can't say it, hemolytic reaction. This one happens when the person's immune system sort of recognizes that, oh, it's not mine, it doesn't belong to me, and it goes and destroys every red blood cell. And so that's bad because then if it basically breaks it off or destroys every red blood cells that they're getting, then that's literally going to cause a sort of a collapse in the vascular system, like a shock, okay? This usually happens within the first 15 minutes. That is why it's so crucial for us to stay with the client for the first 15 minutes. And then the patient could experience fever, chills, back pain, almost like a flank pain, chest pain. They'll have hypotension. They'll have like a rapid heartbeat, trouble breathing, and they could even go into cardiac arrest and death. Okay. For here, of course, we always stop transfusion. We get like a blood or urine sample. We monitor and maintain the blood pressure with fluids. So we'll wide open that normal saline, and then give diuretics to maintain the urine output because whenever the immune system breaks or sort of destroys these red blood cells, it's sort of filtered through the kidney, so they go into sort of like a kidney failure. So that's why we give diuretics to maintain that urine output. So that's the worst of the worst, the hemolytic reaction. And then last, as a adverse reaction or complication is that fluid overload. You kind of want to be careful with cardiac or renal patients because the risk of developing fluid overload is higher. I have seen in my practice where physicians might be wanting to give blood transfusions to someone that has, let's say, congestive heart failure. And what they'll do is that they'll order a diuretic in between each unit of packed red blood cells. And now let's think about that. You're wondering, oh, well, why would they do that? Well, yeah, I mean, if I'm giving them, let's say, 300 mLs of fluid, but then in between the next bag, I give them a diuretic, they'll excrete that extra fluid, bringing the risk of fluid overload, um, being less. So that's why they do it. The first time I saw that, I was like, huh? But then, now I understand. So here's just like a little easy to read. You're welcome to pause the video. Same with this one. And as always, my references are the book, and all my images are from Google or the book. I hope this was helpful, and I will see you in the next video. Bye bye.